On behalf of the Training and Capacity Building Committee of the Chronic Pain Network, I'm welcoming you to our Hack-a-thon showcase. My name is Lynn Cooper. I'm a person with lived experience with persistent pain, and I am the co-chair of the TCB committee with Dr. Rachel Bosma, who is joining us in transit today. She'll be with us as she can. As we begin our time together, I would like to read a land acknowledgement. The Chronic Pain Network is headquartered in Hamilton, Ontario, which is the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. As a national network, CPN and its researchers are committed to working with First Nations, Inuit, and Métis peoples across Turtle Island to decolonize health research and to improve health outcomes for Indigenous peoples. And all who are in attendance today, I invite you to honor silently in your own way the lands on which you live, work, and play, and the peoples whose lands we are living on. Thank you for that. Our agenda is so exciting today. Most of the time will be spent learning from our adult and pediatric hack teams. I'm going to share a little bit of background about the hackathon and then just a few closing remarks. So the hackathon began, as I like to say, with a scathingly brilliant idea that happened during one of our brainstorming sessions of the Training and Capacity Building Committee at the CPN retreat in 2023. And here we are through development, discussions, and lots of work by the hack teams to land at what I think is a true milestone for the network with this hackathon showcase. We created the hackathon as a national team-based program designed to spark creative, actionable solutions to real-world challenges in chronic pain. And we created it to empower trainees, researchers, and people with lived experience in the network to work together using tools from knowledge mobilization and implementation science. Our priority topics were selected through the network's People with Lived Experience-led priority setting initiatives, and they were refined by the KMIS committee to ensure that they're timely, they're impactful, and they're well-suited to collaborative hacking. So in this first year, the two interprofessional teams were formed, each hacking different challenges. The adult team's overarching theme was that of increasing knowledge and understanding of chronic pain, both within the healthcare professionals and within the community. The pediatric team's overall arching theme was developing strategies to improve access and delivery of evidence-based treatments and coordination of care for all Canadian children and adolescents with chronic pain and their families, with a view to reduce disparities. Just imagine everyone thinking about those overarching themes and then coming up with a solid hack that you can work with. And now we, after months of work where the teams received mentorship, training, and funding to co-develop and implement projects, here we are ready to hear their presentations. And I really feel that the work teams that you have accomplished now really drives forward the vision of the Chronic Pain Network, and that is changing the way pain is managed in Canada, the way it's approached. And so everyone in attendance, please join me and in becoming part of the cheer team for our hack team presenters. And now I'm going to turn this presentation over to the adult team. When they have completed their presentation, and the same for the pediatric team, we will be able to come on camera and ask them questions. So let the presentations begin.
Well, good morning. Thank you very much. Dariana, can you share the...
Okay, can you see my screen?
Yeah.
Great.
Well, thank you very much. For those who don't know me, I am Natalie Espinosa. I am a Peruvian family physician, now doing a PhD in community health in Quebec under the supervision of Professor Annie Leblanc. So thank you very much for this opportunity to present. The members of this team are Doriana and I as students, and we have Jennifer, Rachel, and Swapnil as also members of our team. Next. Okay. Thank you. So where did this started? Well, it started last year when we were all called to participate in the hackathon opportunity. So we started to work and to get together initially in 2 meetings before the in-person CPN retreat that was in October. So during the month of August and September, we started to get together to know each other, to learn from each other's experiences, to brainstorm, and to decide in which, to which theme and problematic we would like to focus and arrive to the retreat in October. So, okay. So we decided to work and to focus with communication. Communication coming from seeing it as a problem, but focusing on how we wanted to address this, orienting it to develop skills for healthcare professionals, clinicians, and researchers. So this is how we came up to starting to brainstorm and decide to mobilize ideas to improve communication in this population. Next. So why? That was the huge question even between us as a team, and again, when coming back to our own experiences as students or professionals in each of our backgrounds, we saw in the literature that there was a lot of reports of bad quality of interactions, lack of satisfaction, lack of good communication and connections between the different healthcare professionals and people living with chronic pain. So these experiences were not improved because of this barrier that was lack of connection and communication. And it didn't just affect a single population, it was affecting people with chronic pain, chronic non-cancer pain, chronic cancer pain, people with also vulnerable populations and marginalized populations also were affected by this. So we saw that it was a universal problem that we wanted to address. Next. So how our work was organized. After the retreat, after the in-person retreat, we started to have bi-weekly meetings. We tried. We even set up a Outlook calendar that everybody accepted at the beginning, to start to work like to make a plan and start to work calmly since November to get to May with a product. So first we end up developing our acronym. After brainstorming and talking and showing up to the meetings with articles, we ended up like growing or creating an acronym of action coming from our notes of the meetings. So what we did at the beginning was to assign each letter to each student participating in our group. And the idea was to look for evidence. Well, first to define the letter, then to look for evidence in the literature to support the recommendation we were providing on each letters. Then, in order to show examples and lived experiences, we contacted different professionals from the CPN group, different patient partners from the CPN group, and also from here in Quebec. And that's how, well, when they accepted, we offered them the opportunity to participate in the way they wanted, or providing a video with a testimony, writing a testimony, sending audios, sharing photos. So participants were free to share their lived experiences in the way they wanted. So that was very nice. And we also counted with the use of Articulate as a platform to help us to land our idea and to create each model from each letter. Next. So these are the famous letters I'm talking about. This is like the acronym and the framework we end up creating. So it's caring. So what do we want is to just using a word to set up the idea of there are things that we can do to improve communications. We want to like learn a new way of working and talking with people. So C of connect, A of ask, R of respect, I to inform, N of nurture, and G to generate trust. Nurture the relationships, inform like with truth and evidence-based information, to respect people wishes, people points of view, people like even plans of life. To ask means like to ask about pain, like to really wonder and dig if people are feeling pain and not just assume it or ignore it. And to connect means basic human relationships, right? To have a relationship with your patient. We work to translate it to French also to be able to reach it to more population, to more people also in this French side of Canada. And the equivalent is swan. I tried to make it 6 letters, but the best translation was to 5 letters. So this is our like image that we would like to have, like to easy access, to quick reminder, but we also develop a one-pager in which we, for each letter, we have even an example. So a longer definition and even an example, like this is what you could ask, this is what you could say, like faster and easiest way for students or professionals to remind what we were trying to say in each letter. So again, in English and in French. So this is the first part. These are the first 2 deliverables that we did. The small one can be shared on social media. The biggest one can be then printed and put it in classrooms, I don't know, in the consultation. But this is the first part. Oh, something I didn't say, I'm sorry, is that we ended up being only 2 students, life reasons, academic reasons. Even one of our members is in the other side of the globe, finishing her PhD. So we started as 5, now we're 2, but we respected also and included their point of views until they participated. Thank you. Oh, it's Doriana next.
Yeah, so I'm gonna, thank you, Natalie. So I'm gonna just follow through with what actually we created. So this was just like a start to have like a concrete infographic that we can share. And then from there, we decided to create a training module. So what we did after, so as Natalie started to share, so we created a training module that I will go through the training module towards the end, so you can have an idea of what we're talking about. And we create a training module that includes 6 modules, which is corresponding to each letter of the acronym. And for each model, we have a similar structure. I'm going to go through the structure in the next slide. The module overall might take around 1 or 2 hours. So obviously we have a lot of resources that can be like journal articles or things that have been already published, that if people go through all of the resources, they might take a little bit longer. But overall, if the training, if everybody goes through every module, we think is going to take around 1 or 2 hours, 10-15 minutes per module. And the modules is currently in English, and we have some resources in French, because we have people with lived experience that speak French. So we have translated those content. But obviously, our idea, if we actually end up disseminating this, we want to fully translate the module as well. Unfortunately, we didn't have enough time to do it really nicely. So for now, it's mostly in English with some French as well. And then, so our idea is that this module can be integrated into medical education. So that can be medical university, so medical students or healthcare practitioners, or even clinicians that want to do continuing medical education. So we could think about giving credits for this. So we need to kind of figure out the best way to integrate this in what's already out there. So that's how the training module, the format of the training module looks like. And so I'm going to go through the actual platform in a moment, but this is just to explain how how the module looks like. So this is kind of the preview of the page if somebody starts the module. And then for each letter, so we have an introduction of the module. So there is one introduction module to explain what's the caring model and how we came up with this framework and why. And then for each letter, we have, for instance, this is an example of the C. So we created like 4, sometimes are less than 4, bullet point to kind of explain what this kind of letter means for us. So connect through careful and empathic conversation. What does that mean? So we break it down in appropriate communication, providing clear diagnosing information, listening, showing empathy, validating partnership. And obviously we didn't come up with this just out of nowhere. We did a search in the literature, and then for each bullet point, we provide evidence. So that's normally journals or resources that have been published in the chronic pain space, but also cancer and non-cancer pain. So each of the bullet point then gets expanded a little bit more with evidence. And also we have some videos or some quotes or a testimony from people with lived experience within the network, or clinicians, researchers. So I will go through the module probably after, because it is nicer for you probably to have an idea on how the module works. And then each letter ends with a demo video. So it's a demo video. How we created it is basically kind of an example that we can give to the person that is going through this training. How could you implement this letter? So how can you connect through careful and empathic conversation in real life? So we have kind of a small dialogue where we have a patient and a clinician, and we kind of give an example on how the clinician can, in real life, implement this suggestion. Obviously, these are just suggestions. We say that in the video too. We're not asking people, this is not like advice, but it's based on evidence. So we're trying to kind of give some guidance. And just I'm taking a moment to just thank everybody in the network that came up to us and gave us suggestion on how to change the scripts and how to kind of modify all this content. And then at the end of each letter, there is a reflection exercise, so that the person that is engaged in the module can take a moment to reflect on what they learned in each module. And then, so we're thinking that obviously if we decide to make this training also part of credit in continuing education, we might add a quiz at the end of each sub-module, at the end of each letter, and then at the end of the module, so that we can release a certificate. But we need to figure out all the kind of procedures after this. Okay, so that's the basic structure. And then, So how was the content developed? So we said before that Natalie was mentioning that we did a literature search, and we found that actually there is a lot out there. There are a lot of papers that are talking about how empathic conversation, communication with patient can improve patient satisfaction, but also improve and treatment overall. So based on this, we try to kind of select those papers that were mostly important for what we were looking at. And also we try to connect with pain clinician, researchers, people with lived experience, especially within the network, to hear their perspective. And then again, we came back to some of you probably in the network to just say, how do you feel about these colors of this graphic? And how do you feel? So that was really helpful because we had a lot of nice comments and also things that we were not thinking about. So then we came back with those feedback and we created what the module looks like right now. And then also within each letter, we have different formats. So we don't have the same formats for all the content that we have. So some people have done videos, some people have done quotes or like notes. Voice notes. So we try to keep the content a little bit different so the users are engaged. Yeah, so then I'm done for this part. So I'm gonna, if you don't mind, I'm gonna just show, I'll come back to the slide, but I want to show the training module. I'm gonna switch screen, second. Okay. Okay, can you see my screen? Okay. Okay, so that's how the module looks like. So this was done in Articulate. So thank you to Rachel and Rachel Bosma for suggesting this, and also to the CPN for funding this opportunity. So so this is the preview. So obviously, if somebody does it on a tablet, it's gonna look like this. If somebody does it on a mobile, it's gonna look like this. So this is my desktop preview. So if I click start course, so this is what the caring model is. So we explain, so I'm not gonna go through everything, but I thought I would share just the intro video and then maybe one letter, so you have an idea of what that looks like. And then if people want to know more and see the full module, I can send information after. So this is the introduction model. So we have this, I'm just gonna scroll through, and then we have a framework. So how we came up with this, the framework behind. And then this is a small video that is kind of an introduction to the whole course. So I'm gonna play it, hopefully it works.
Welcome to the Caring Action Training Series, an interactive, self-paced set of modules designed for effective communication in chronic pain care. Each letter of the Caring Framework has its own dedicated module. In each module, you'll find evidence-based insights to help you embed communication tactics into practice, real-world perspectives from both clinicians and patients, and the short demonstration video that brings each tactic to life. These videos are not intended to offer clinical treatment advice. Instead, they highlight brief, realistic interactions that show how small shifts in communication make a big difference in patient care. The content for this training series was developed in partnership with people with lived experience, clinicians, and researchers.
Okay, so this is the intro of the first module. So that's what's the evidence, that's the reflection exercise. So that's just the intro. And then every letter goes kind of like this. Maybe I'm not gonna take time to go through all of them, but I wanted to show maybe this one that has kind of a different content. So this is the G, so generate trust by acknowledging the reality of pain. So we just, in each module, we just remind about the caring model, what it is and why, and we just have a visual of this. And then what does generate trust by acknowledging the reality of pain mean? So we have 3 bullet points: validate individual experience, avoid making assumption, implement a patient-centered approach. So for this one, we had a testimony from a person with lived experience, Sandra. So we have a note. Maybe I'm not gonna play it all, but maybe I can just start. So she's just explaining, she's talking in French. So she's sharing her experience. So we have the translation. Obviously, we have her consent to share these pictures and these notes. Yeah, so that was in French. So we have the French, and then we have a click for the English translation. Like in real life, if we end up making this nicer, we might want to like have a transcription of the English. So we have so many ideas, but we had to kind of manage the time and people that we have in the team. So we try to keep it like simple in a way. And then, so this is another note from Sandra that is sharing like her experience with cancer, breast cancer pain. So that's the translation of the other note. Yeah, so that's another note, and again, the translation. So that's just an example of what one module might look like. And then we have, again, evidence from the literature. So then if somebody clicks, it goes to the, okay. It goes to the papers that we included. So again, that's why I was saying if somebody wants to go through all the evidence, that is going to take a little bit longer than an hour. But we leave the options, and then people can explore more or less as they like. And that's so the second one, avoid making assumptions. So again, that's we explain why that's important, and then implement a patient-centered approach and why it's important. So again, this is what's the action. So here we have a demo video. So I'll share this one as well, perhaps, so you can have an idea on what a demo video looks like. So in every letter, we kind of explain briefly what's the caring model again, and then we give a little demonstration of what can be said during interaction. So I'm gonna play this.
Welcome back to the Caring in Action demonstration video series. Each short video aims to bring to life one part of the caring framework by demonstrating effective, evidence-based communication for clinician-patient interaction on chronic. In the caring framework, the letter G stands for generate trust by acknowledging the reality of pain. So what might this look like in an interaction? Let's look at it.
Sometimes I feel like people think I'm making this pain out to be worse than it is.
I hear you. Chronic pain can be visible to others, and that makes it easy for people to make assumptions or dismiss what they can't see.
Yes, exactly. It feels like no one really gets how much it impacts my life.
You're not alone in that. I believe you. And what you're going through deserves to be taken seriously. You know your body best, and I trust what you're telling me. I want you to feel comfortable telling me when things are or aren't working for your care.
I appreciate that more than you know.
Saw how trust is built when clinicians validate experience and acknowledge the reality of their pain. When patients feel believed and supported, it helps break down stigma and fosters a stronger, more open partnership.
Okay, so that's an example of how every letter kind of is structured, and then that's a reflection of the exercise. That's the same for each module. And then I can just show their last module. So this is just a recap of what we have discussed through the rest of the modules. So the key takeaways are just here again. And then here we have additional resources. So we just added like more information. So if people click, they can get to the CPN Plus, Canadian Society Power Over Pain, Pain Canada, Action Plan for Pain Canada. And then here we have the graphics. So they can choose to download the graphic if they want to have it in the clinic with them, or also the one pager. And then we added a reminder that can be printed in black and white for accessibility. This again, thank you for the network that was thinking about all these details that were very important. And then so the optional tools like a worksheet or a checklist for use during the appointment. So we could think about also adding the quiz at the end of this. And then just some of the people that have contributed to this. So people with lived experience, and also people, our friends and people that have donated their voices for the demo video. So yeah, it's been a teamwork. And then I'll quickly go back to the slide just to kind of reflect on what we'll learn from this experience. So yeah, so our future plan for this is to possibly fully translate the module in French and improve the content quality, because again, like we always can do better with each with all the things we had, we were noticing like some minor things that we could improve, like sound and like more flow and fluidity for the video. So if we end up disseminating this, we hope we can improve the content quality, and then we would hope to also integrate the module with other university across Canada, and also hear from the network, perhaps Spain, Canada, if they can help us to kind of share this. Yeah, so we are also considering, it's very like ambitious if we manage to do so, but there is a grant application through SPORE, dissemination grant through CIHR. So we are trying to perhaps come up with proposals and see if we can actually get some money for this project to be actually disseminated. So if we manage to perhaps get some funding for this round, or maybe next round through CIHR, we could use that money to translate, to make it much nicer, and maybe integrate it across Canada and through the network as well. And then this is just lesson learned. So we learned that it's very important to be collaborative. So to try to collaborate and even like leverage the expertise of everybody within the network. So from people with lived experience, we had so much like nice conversation and engagement with many of them, and also clinician and researcher that gave us their perspective. And also, I would never say enough thank you to Rachel, Roy, to Jennifer Swapnil. They were great in the team, giving us their perspective and even their knowledge about what's already out there, how we can connect those things. And yeah, again, the input from the network was crucial to initiate the initial connections, but also to kind of improve our content. And yeah, we learned that we can always do better, but we need to settle at some point with what we have and what we can do. So yeah, that's everything from us. And then just, yeah, to acknowledge everyone. All the names are in the module, but yeah, it was a work that would have not been possible without everybody contributing to this. Yeah, so then I will turn it over to everyone. Stop sharing.
Before we do questions, can I just point out, is that okay, Lynn? Can I just say one thing?
Please.
Just as working as technically the title was mentor, but I feel like we were all just peers, and it was amazing to work with Doriana and Natalie and Jen and Swapnil. But just to really emphasize that this team started with 5 students, and in the end was just 2 people who pulled together like a literature review. They had like an iterative, responsive process while both working on their PhDs. And it just was so impressive to watch and be a part of and support in any way that I could. But the passion was really there, and the willingness to take feedback, I think, was such an impressive piece of work as far as a knowledge mobilization skill set and capacity building piece. Cannot say enough. Also, if anyone on this call would like to maybe contribute a letter of support for that CIHR dissemination grant, you are welcome to do so. But now we can open up for questions.
Count on a letter of support from me. Amazing. Natalie, Doriana, Jennifer, Swapnil, Rachel. An incredible amount of work we can't even begin to know. And Rachel, you've outlined the workload very well. And what an amazing product for knowledge mobilization here. So we have time for questions and comments, everyone. So if you're able to, please come on camera to ask your questions, and over to you. Rachel, Roy, maybe you can help me to monitor all the screen here.
Sure.
Right now I'm not seeing any questions. I would have a question for the team. So, first of all, and I see Vina, when is the grant application going in? People need to know that so
Yeah,
that we can get
Yeah.
behind you.
The
that's
deadline, oh, sorry, go, Doriana.
like that's the 19th of June, so it's very, very.
Oh,
So we are
No
trying
problem.
either if we can manage this round, we could do the next one, but this is very tight if we do this one. Yeah.
Yeah, we can help by providing maybe a draft that you can edit according to whatever you need, and then like to save
yeah,
time.
yes. That for a letter of support, that makes sense for sure. Vina,
Yeah, thanks, Lynn. And thank you to Rihanna, Natalie, and Rachel, Jen, Sapnil. Thank you all for your amazing hard work for this hackathon project. It's so amazing to see the products and how beautiful they look. And as a person with lived experience who also got those emails, it was so wonderful to see how amazingly you engage people with lived experience, queer, gender diverse, trans people with lived experience, and all of that really matters in the final product. I was actually just going to suggest that potentially for dissemination, I might reach out to organizations like the Trevor Project or other like queer organizations to see if maybe they can also help support dissemination. I mean, we know pain impacts so many people on Turtle Island. So, you know, getting kind of like that stamp of approval from some of these organizations might help with dissemination and move beyond just like the networks that we know of. So, yeah, that's my only feedback, but amazing job.
thank you, Vina.
Yeah.
Nader, the hackathon was your scathingly brilliant idea. What do you think? And what's your
Don't blame me
question?
for I think
I'm
this was really so this really did exceed my expectations of what I thought we were gonna get from the hackathon, and I think that uh it's really an impressive amount of work, and you can tell that a ton of time and resources went into this. Um, I think that the planning and dissemination grant is a wonderful idea. And I think that it so I'm not sure if it should be run through the CPN or run through a PI. That's a question that I think the team needs to discuss about the best strategy to get it out. I'm happy to help run the application in for the group, but coming from CPN directly may be a smart move. The other thing I wanted to mention is um, we want to think of this as a long-term project, right? It's not something that's going to go out and then the team kind of washes their hands of it and says, okay, it's out there and now it's done. I think that this is something that can and will evolve and something that will likely grow. And I'm one who doesn't like to stay in the walls of Canada. And I think that this is something that could go international. And I think that thinking along those lines and getting the input of people across different ethnicities and cultures will be important for this. And see how it might be able to be translated across cultures and languages. The other thing I would suggest is to either via the planning and dissemination grant or from other funds that may be available to set aside um, funds for a resource center for people who will have questions about the modules. So I could see people doing these modules and then coming back and saying, I have questions. I'd like to work with the team, or I'd like to update something, or I want to know what's, these kinds of back and forth will take time and effort. And I think that we may want to squirrel away some funds to make sure that that can happen and it doesn't die within a year, let's say, of being released. Because I think that this could be something that does change how training is done and how people think about pain care. Just a bunch of
Amazing, amazing ideas,
Thank you.
comments. Katie?
This was really a pleasure to watch and really impressive. So congratulations. I may say something that's a little bit counterculture in the knowledge mobilization space, but it's something I've been thinking about a lot lately. I would write a peer-reviewed publication about your development process of this tool. So I know, like I said, I know that feels like counterintuitive, and I think all of these other knowledge mobilization ideas are like stellar. And I think there's increasing spaces in the literature to talk about the co-development process and to model that. I wouldn't overcomplicate it, right? So but I just would encourage you to also put it out in that space.
Oh yes, we were discussing about it, but we first wanted to get the models and everything ready for this presentation, to present it, and then to sit down again to write our process manuscript. Yes.
Yeah, and then I'm going to do a ridiculous plug, which is shameless, which is the special issue in Canadian Journal of Pain that CPN is partnered on. They're not due until next January, focused on knowledge mobilization and implementation science. And that would be a great place. As part of the reason we developed that article collection. I've got other great journal suggestions, but I would be remiss if I didn't make a shameless plug there.
If you
That's
didn't plug it,
amazing.
I was going to, Katie. So yeah, it's a great plug.
And one last comment, Rachel, Roy, would you like to mention about U of T? And then we will go on to our next presentation.
Sure, just in the chat there as well. It's just that we've had some discussions, not necessarily a full promise, but that U of T would have interest in helping to embed this module within their existing interdisciplinary pain education piece. So we would refine it a little bit before that's able to kind of get embedded there, but that is a very exciting piece for this team, especially.
Yes, so lots of positive feedback here, team. Lots of opportunities, thinking forward, nationally, internationally, where to publish, getting support for your applications. So I know you said you felt very supported through all of this, but you can hear from the comments today that we so appreciate your work and see so many positive opportunities for you. So thank you. And now I would like to turn the time over to the pediatric team with Megan McNeil and the team. Take it away.
Thanks, Lynn. I think Kelly is just going to share for us. Okay, amazing. Hi, everyone. My name's Sabina, and we're so grateful to be here with you on behalf of the Pediatric Hack-a-thon team. We're a team of diverse folks who came together to figure out ways to bridge the gap between research and access with a lens to reduce disparities. Next slide, please. So we know that an overall land acknowledgement has been done, but it's incredibly important to recognize where we are in the space and kind of across Turtle Island. And these lands, as has been said earlier, have been cared for since time immemorial by First Nation, Inuit, and Métis people. But colonization continues to shape the conditions of this land and peoples. So it's important to us to honor the resistance, resurgence, and leadership of Indigenous communities. In terms of our group, group, we are all settlers living on lands taken through violence, broken treaties, and systems built to uphold white supremacy and embrace Indigenous resistance. We acknowledge that complex histories of migration, imperialism, displacement, and structural violence shape our presence here. And we understand that it's important to us to commit to solidarity. Sorry, Kelly, next slide. That's rooted in our accountability. And we affirm that all liberation is connected. And as Bell Hooks says, love is an ethic. And for us, that ethic includes land back, Indigenous sovereignty, and refusing colonial structures in our research and practice. And this means showing up differently in these spaces and centering Indigenous knowledge or decolonizing our knowledge, naming our complicity, and building futures grounded in reciprocity rather than extraction. And of course, naming that we would like land back and supporting calls for Two-Spirit missing murdered Indigenous women and Two-Spirit folk. So next slide, Kelly, thanks. So in terms of our team, this is us in a nutshell. And when we first met, we really took stock of kind of all our different perspectives, and we didn't see our diversity kind of as a box to check. It was the foundation of our methodologies. So, this is who we are, how we see, and how we approach this hackathon problem, and also how we chose to show up with care, imagination, and passion. Our team's lived experience wasn't bias, it was knowledge. So when we were asked, how do we build something for youth that look like us? Not just something that is evidence-based or technically accurate, but something that feels like care, that teaches, that names harm, that resists, and that affirms to youth, your pain is real and so is your power. Next slide, please. So as Lynn so wonderfully said, our job was to design and implement a knowledge dissemination project to improve access and delivery of evidence-based treatments and coordination of care for all Canadian children and adolescents with chronic pain and their families with a view to reduce disparities. So, super easy. I can do that, but no, it was definitely not. And that's why, when we were approached with this challenge, it was important to us to discuss and learn and understand the context of disparities and what that actually means. And what we found is that in our discussions is that newcomer youth are everywhere in our systems, but they're often not seen in our data. They're often rendered invisible by practices that see whiteness, English or French, and citizenship as default. So it's incredibly important to us to use an intersectional foundation to this work. So we asked, what does it mean to navigate chronic pain while also navigating immigration, racism, language barriers, and poverty? And in this climate of 2025, where migrants are often being, there's massive xenophobia. And how can we hold space and knowledge mobilization for layered experience rather than flatten that into a tokenistic experience? Next slide, please. Many newcomers are displaced by colonialism, war, or climate change, and many live in households where survival is prioritized over care. And many have been told either explicitly or implicitly that their pain doesn't matter or isn't real. So it's important to us to say, your pain is real, you matter, you're not alone, especially given almost 50% of Canada's population will be people with experiences of migration. So we chose to define our population as youth newcomers to Canada, and this is anyone who is an immigrant, a refugee, undocumented folks as well, and they were adolescents, so age 12 to 18, given that in most care systems across Canada, most people transition into adult care at age 18, and we're looking for folks who kind of immigrated to Canada in the last 5 years, specifically because it takes about 5 years to become a citizen here. And granted, that's not the goal of everybody, but we needed kind of a timeline to consider what is a newcomer. And based on our literature, this is kind of what we found. We also saw that chronic pain is hard to access, especially for newcomers teams facing racism, stigma, and language barriers. And again, that xenophobia that we're seeing very prevalent in 2025. So our goal was to create a hack or a guide that helps youth understand their pain, how to access care, how to navigate these really complex systems, and understand their rights so they're not left alone when they arrive in our care systems. Next slide, please. I'm going to pass it over to Mika to describe our process.
Thanks, Mia. And so in terms of our process to develop the guide, we first reviewed the literature and existing resources. We listened and learned from newcomers with pain, and then we developed and refined the content that we created. And our last phase is to disseminate and mobilize this knowledge using an iterative process. So making sure that we can come back to it, ensure that it reflects what it needs to. And something that I want to highlight as well is that throughout this process, we were informed not only by evidence and training, as well as the experience of those living with chronic pain, but also the migrant experiences of those among our team that really shaped these discussions and processes. And so in terms of phase one, the review, this was important because in order to disseminate the knowledge, you first needed to understand what it was you were disseminating and what was actually available in the timeline that we were given. And so we chose to do a rapid evidence synthesis, not just in the scientific literature, but to the public more broadly. So our steps were to review the information and about kids' health, the existing evidence around chronic pain in young newcomer populations, and then to compare, contrast, and synthesize all of these evidence sources in the short timeline. And so we chose About Kids' Health because it is a comprehensive health education resource for children and caregivers that is primarily managed by the Hospital for Sick Children or Sick Kids. And because of that, it provides reliable and evidence-based health information that is reviewed and approved by health professionals. Because it is available online, it helps to make healthcare knowledge more accessible to individuals. So again, we're thinking about our goal of reducing disparities through our work. And the information is also available in more than 9 languages, which is very important for the population of focus who may not be as proficient in English. We also want to note that we have existing relationships with people in About Kids' Health, which helps to ensure that our work is going to be available and is going to be put on a platform that can be disseminated. And so another reason why we chose About Kids' Health is that their pain hub is currently undergoing redevelopment. And we wanted to leverage this opportunity through this hackathon. And in this hub, then integrate the culturally informed and evidence-based practice that is that will be included in our guide on this website. And so in order to do that, we're aiming to develop a toolkit for newcomer youth with chronic pain that will be available on this site. We also wanted this project to be co-developed with patients and people with lived experience, not just of pain again, but also of migration and being racialized and all these other intersecting identities and experiences that can impact pain care. And so, and when you look on the next slide, we have the community resources that we're hoping and that we have tried to leverage as much as we could. So as you can see, we're using About Kids' Health and we're trying to take opportunity from that, but also going beyond that and seeing what other organizations that we can connect with to really make sure that our dissemination and reach is maximized. So that includes the Government of Canada website, Caring for Kids New to Canada, as well as resources for newcomers and for youth with pain. Next slide, please. And so in terms of our findings for evidence synthesis, let's start with what About Kids' Health has. Again, it's evidence-based, and so we know that this information is grounded in the literature as well. And so it talks about what chronic pain is, defined as continuous or recurring pain for at least 3 months. It also talks about the factors affecting chronic pain. When we look at the assessment and diagnosis, it details the behavioral signs of chronic pain, as well as the use of pain scales in older children. And lastly, for treatment and management, it talks about the 3P approach for pain management primarily, which includes psychological, physical, and pharmacological approaches. But when we're thinking about reducing disparities, we want to also highlight what it does not have, and that's primarily also because the literature that we currently are basing this off of does not necessarily reflect the experiences, again, of those who are underrepresented in the first place within this literature. So what examples we found were that in terms of definition of chronic pain, we currently don't have on the About Kids' Health website rather, the definition that chronic pain is also disproportionately affecting equity deserving youth who have increased risk and increased healthcare disparities as well as barriers to accessing care, which couches the impact of chronic pain and the disproportionate burdens that it has, especially on those populations who are marginalized, like newcomer youth. For assessment and diagnosis, it does not detail how pediatric chronic pain is defined and experienced in other cultures. Again, thinking about what Fina had said earlier, we're currently using this more Western definition, but that is not necessarily universal. And for treatment and management, it does not detail the cultural ways of pain management, such as prayer, exercises like Tai Chi and yoga, and herbal balms or oils that may work for other people, but are not well recognized or talked about in the literature that we're basing this off of. And when we're thinking about where these gaps fit on this next slide, we can see that it's really evident throughout age groups in youth, as well as in the parenting practices for children with chronic pain, which details the need to really think about what we're doing in our research and care if we want to reduce these disparities, to make sure that we are culturally responsive and we're caring for the person in light of all their intersecting experiences. And I'll pass it off to Joseph for the next phase.
So before beginning the design process, we knew it was essential to meaningfully engage and, more importantly, listen to youth with lived experiences of chronic pain, and particularly those who are newcomers to Canada. So we recognized that any resource that we developed needed to be grounded in their perspectives, challenges, and priorities. Next slide, Kelly, please. So we launched our work by creating a clear and accessible call for youth patient partners. It explained the goals of the project, what participation would look like or would involve, and the patient education materials we hoped to co-create together. With the support from the Chronic Pain Network, we circulated this call widely through the CPN Pain Connect, clinician networks, community organizations, and youth groups to reach young people aged between 12 and 21 with lived experience of both chronic pain and migration to Canada. Our goal wasn't just to consult, it was to collaborate. While we initially hoped to work with 2 or 3 youth, time constraints meant that we were able to engage only one patient partner. While we acknowledge this might be a limitation of the current project, the contribution of these person were incredibly thoughtful and meaningful, and they shaped the direction of the project. Next slide, Kelly. Our early conversations focused on 5 key areas. So we focused on her experience with pain and accessing care, the support systems and gaps, resources she used and has been using, her feedback on existing about kids' health content, and finally, her ideas for future directions. Unfortunately, we only had time to explore the first 2 topics, but we are planning to return to the remaining topics as our collaboration continues. Next slide, Kelly. She shared compelling reflections about her own experience and navigating the healthcare system with chronic pain as a young newcomer in Canada. She described long wait times, not feeling heard and believed by providers, and the lack of continuity across services. Different practitioners would ask her the same questions over and over again every visit and wouldn't be involved in their care beyond patient rounds. She didn't feel engaged in her care at all. When discussing support systems, she emphasized the isolation she experienced and how much she relied on self-advocacy and online communities. Next slide, Kelly, please. One key theme that emerged was the importance of supporting youth in learning how to advocate for themselves. Suggestions included creating tools like a personalized badge to streamline triage, tips on using language that communicates urgency or legitimacy, and better information on how the side effects of common pain medications. She also highlighted the need for clear, youth-friendly information about how the Canadian healthcare system works, especially for those that are unfamiliar with its structure and policies. These ideas are, of course, shaping the foundation of our resource, and we are very excited to continue co-developing it with youth to ensure it is practical, accessible, and responsive to real-world needs. And I'll pass on to Kelly.
So from our rapid evidence synthesis and patient engagement, we applied our learnings to then develop and refine our hackathon product.
What we came up with is It's Not All in Your Head, which right now is a Word document containing over 15 short form articles that's ready for input into About Kids Health. Our hackathon content covers topics such as stigma, discrimination, equity, racism, and marginalization, really talking about what these concepts are and what they might mean to a newcomer who's navigating the healthcare system in Canada for the first time. We also aim to provide some reassurance, so really talking about how pain typically presents in many chronic pain populations, but also how it can look very different for everyone, and acknowledging that because of this diversity, sometimes healthcare professionals or other people in your life may not really believe that you're in pain. We offered some more practical content that newcomers with chronic pain may find useful when they're navigating the healthcare system for the first time, like how to access care and what your rights are, what to expect at an appointment, what is expected in the 3P approach to pain management that is used in Canada, and how you can adapt it to things that already work for you, and what does it mean to access multidisciplinary care, and what other additional services do you have access to. So that's where we are now. We have 15 short articles written and ready to integrate into the About Kids Health site update. Our immediate next step is to have this content undergo some final subject matter expert and patient partner review while we wait for About Kids Health. Next, I'm going to talk about some future steps after the hackathon. Well, first, we want to share our KM product with different consumers and get their feedback. Here we've presented a couple in mind. So, of course, our patient partners and people with lived and living experiences, our CPN subcommittees, our Kids Health, About Kids Health, SKIP, and the National Newcomer Navigation Network. After obtaining and integrating this feedback, we want to work on disseminating and mobilizing our KM product. What are some ways that we can do this? Of course, these ideas pertain to next steps that are beyond the scope of the hackathon, and we would really want to engage with consumers to determine what strategies would be the most effective. But some ideas that we're proposing here include an e-learning module with quizzes, paper materials like brochures and posters, social media posts, videos, infographics, and community-based workshops and webinars. Of course, we want to publish our final content on About Kids Health, but we also want to engage and share our product with other pain organizations listed here. Most importantly, we want to engage and share our hackathon product with organizations beyond the pain community to ensure that we really reach the right people. So here we've included some well-known community, cultural and newcomer organizations, as well as community organizations like the Sickle Cell Awareness Group of Ontario, YMCA, and Boys and Girls Club. We want to evaluate the success of our KM product, and there's multiple ways in which we can define success. This includes whether or not we engage with people with lived and living experiences, whether our KM product is successfully taken up and used by our partners, and the extent to which our product is engaged with using reach and use indicators. Lastly, our work with the hackathon product isn't over. So to further promote accessibility and relevance, after this work, we want to really create future iterations of our KM product. And this will include translating it to multiple languages, adapting the content so that's more specific to different newcomer populations, and adapting the content so that it's specific to different pain conditions as well. And I'll pass it off to Vina.
Thanks, Kelly, Joseph, and Mika. So now we'd like to share some reflections on what we learned through this process. Next slide, please. So, along the pathway of the hackathon, we had so many amazing learning opportunities. We couldn't even fit all of them here. So we really just decided on focusing on the top 4 things that we did. So we really appreciated learning about knowledge mobilization from the expert, Dr. Katie Burney. We really appreciated the implementation science primer with Dr. Rachel Bosma. We also had that opportunity to do a pitch at the CPN meeting in Hamilton in early October that really shaped everything coming through that you're hearing in this presentation. And then we also had the chance to meet with amazing global content experts who really know this area, understand migration, work with newcomer populations, and we're so lucky to be connected to them and really learn about what's happening in this area. Next slide, please. We learned a lot of lessons, and throughout this process. And I think one of the main things we learned is that the issue wasn't just with the knowledge gaps; it was a knowledge injustice. So it wasn't just about translating the information; it was about thinking about who the evidence is rooted in, who it serves, and who it's erasing. So really, this was a lesson in slow work, in listening, and being okay with being unfinished at several points, and being okay with living in the discomfort of this kind of work. And it really showed that, like, it really made all the impact in our work. And we really learned that good knowledge mobilization implementation doesn't just come from these templates. It comes from our values. It comes from care. It comes from holding each other through discomfort of the complexity and staying committed to our goals and believing that transformation is possible, especially when we when we lead with humility and stay accountable. We learned that knowledge isn't just peer-reviewed journals. It lives in grandmas, youth circles, protest signs, and shared meals together. It reminds us that centering those forms of knowledge is not extra, it's essential. It adds to the rigor of the work when you include people with lived experience, full stop. So, these are just kind of some of our general reflections as well, which is, youth voices, as we said, are incredibly important. Diversity, we learned, is more than just about our good intentions. We can go in a room with good vibes. So it's about building trust with these communities, especially to hear stories of individuals who are undocumented and experiencing the Canadian healthcare system. Translation is incredibly timely and a very complex process, especially for health information, but we're really lucky to have partners like About Kids Health who've done this many times and have all those resources available for us. And we're incredibly grateful for all their support and CPN support and all this work. And really what we learned as well is, we don't have to recreate the wheel, but our goal is to deliver and transform the wheel. So we really have to learn how to develop the next iterations of things, and if not, break the wheel and start again. So next slide, please. So with that, we would really like to say thank you. We're proud of this work, not just because it's perfect, but because it's really principled. It's never going to be perfect, but we can build something in alignment with our values and our commitment to continually grow and learn. And as was said earlier, this is not something we're kind of putting on a shelf and we'll never touch again. This is something that we stay committed to keeping up to date, to maintaining with care. We're hoping to move these folks from where society has placed them at the margins of these different intersections. And really, that's where we had the sharpest clarity and the most lived experience. And we really hope this is the beginning of this work and not the end. We'd like to say thank you to the CPN team, to Prachi, who has been an amazing guide for us along this way and has really just transformed the way we work and we've worked together. Megan McNeil, who is absolutely right by our side through every step of the way, gently making sure we stay on track through the goal, and has taught us so many lessons and how to do this work well. And to our supervisors and superheroes, Katie, Mel, and Jen, our content experts, our patient partners, this work wouldn't be possible without you. And with that, we move into questions, and we welcome your space for feedback, collaboration, ideas for where we can take this work. And thank you so much for the time and space to share all the things we did over the last year together. Yeah, Mel.
Hi, just in my car, dropping my kids off. I just want to say how impressed I am by everyone here. I'm not just saying that, I know many of you, but this gave us a deep dive. I just think what CPN has put together should be implemented this program, and you're the inaugural leaders of it. All of you who did this work, it's just incredible. And yeah, just one question I had. I love when, oh God, and bell hooks in the, that was just the best land acknowledgement I've ever heard. I'm just wondering, as I think about the 3 Ps, and I think, how much are we trying to fit people in systems? How this is it's so urgent. It's this tension, and it's not an easy question, but you know, I just think like even when we talk about the 3Ps, I mean, that was developed by and for certain people within a very biomedicalized, not just system, understanding of pain. When do we break wheels? How do we do it? And I'm just wondering, you know, I know many of you have lived experience, and also this is your area of expertise. Just wondering about that, because we want to mobilize knowledge, and it's tricky in an area where there isn't a lot of knowledge. And yeah, just wondering about that tension. I'm just, again, just so impressed by all of you. Just thought I'd ask an easy question.
An easy question, Mel. That's I can jump in, but I would really love to hear what Joseph, Mika, and Kelly and Megan and Prachi have to share as well. But I think that's really a big issue we noticed, and why this work took so much longer than just writing an article on the 3Ps of pain management. Because when we started to interrogate, like, what are we asking people to do? How are they doing it? What do they truly have access to, and what is safe for them to access as well? And from you know, our lived experiences, but also the lived experience of our patient partner, we learned that these systems are often not safe for people to navigate. We say 3P, but many of those services are private or not insured. And if you're in the waiting period for healthcare, which in many provinces have been reactivated after the pandemic, so you're waiting for 3 months to even see the first point of access to care, you're alone for those 3 months. And really, that's where working with the community organizations helped us a bit, because we learned that they are alone in those 3 months, but they're alone from not from community, but from our systems. So the community is still there with them. They're still there with their, you know, in one of our cases, like, you know, they're still there with the Black and Caribbean community, as you know, and they have care through those methodologies as well. So we really thought, you know, really a lot of this is about decolonizing pain, which is not exactly what we expected when we started this project. We're like, you know, like, but really so many of the things that we tell youth on how to manage, how to navigate, it's all built in huge colonial and white supremacy assumptions. So really, when we were authoring this content, and that's why I think the feedback pieces are so important, it's been really important to us to really identify that it's not the people in this, it's the systems, and the systems are harmful, but you have rights that you should know about. We have like a quick rights advocacy card that, you know, they can keep anywhere with them and remember, like, these are my rights in this health experience, and different things like that we're workshopping still. But I'd also love to pass it to like my group mates to also reflect on that question.
Yeah, I think to just add to that, you know, when you referenced the drafts of the toolkit so far, and I think about also, Mel, when you mentioned the 3P approach, and I was wondering, like, how do I frame this? Because they could kind of fit into that 3P model, but exactly why do they need to? And even in our conversations, as I said, this work was guided by our own lived experiences, and we were talking about our own pain strategies. We didn't think about a 3P model. We just said what worked for us, what worked for our culture, what worked in our background, what we knew that we may not see in healthcare encounters. And I think that ties back to the adult team's communication model to also try and foster that and make that open, right? And so when we're thinking about, again, decolonizing these systems, thinking about how we operate within these systems too, that's a really key message that we can integrate into not just this work, but going forward in order to really make sure that we're reducing disparities, especially for those in most effects.
Amazing. Thank you. Thank you.
And I'm looking at many posts in the chat for the pediatric team, with lots of suggestions, questions. So Megan McNeil, would you like to say a few words about the team?
Sure, yeah, absolutely. I could say so many words about working with this team, but I will keep it brief. I mean, it's as Rachel Roy had said at the end of their presentation as well. You know, you work in this CAM mentorship role, but truly, I've learned so much from this entire group and process, and have been challenged in my own thinking and viewpoints, and how I approach my own scientific work and knowledge mobilization work and community engagement. So just, huge congratulations to both groups who've been so committed, and to the pediatric team here has taken on, as Vina, you said at the start of the presentation, such an easy topic to to work with, but to see how it's grown and transformed over the course of the last the last 8 months or so is really how real knowledge mobilization work happens, right? Especially when we're valuing the importance of community engagement and collaboration, and elevating the voices of of different perspectives and different expertise. So I think this group of trainees has done so with so much respect and maturity and consideration and intention throughout the process, amongst their already really demanding day-to-day responsibilities. And so it's never lost on me for both of these hackathon groups how much this has happened on top of what they already had planned in the course of their regular school year. So thank you to both teams for such a tremendous job, and thank you to the pediatric team for including me in your thinking and process, and learning together with me. Way to go.
Yes, way to go. So I would just like to thank Vina and Prachi, Megan, Mika, Kelly, and Joseph for the work that you have done on your hack. And way to go for looking and leveraging the retooling of the About Kids Health website, and being able to capitalize, inserting the information that you have created, that toolkit that's going to be so helpful to new kids to Canada who have pain, and to their parents, and thinking down the road as to how systems must be changed. Both teams have done that. How systems must be changed, how we can improve outcomes for all people living with chronic pain through knowledge mobilization, in the work that both teams have done, are doing, and are going to continue to do. So I think that the scathingly brilliant idea from 2023, Nader, and the work that we have all done together with the support of the Chronic Pain Network, really looks toward the future. The energy, the collaboration, and the innovation that both adult and pediatric teams have pulled forward on the side of your desk to make the changes, or to spearhead relevant, meaningful changes to the way we look at pain, the way that we address pain for different individuals, and to help the clinicians to have more meaningful and productive conversations with their clients, only benefits the people with lived experience. And I'm just so grateful to all of you for the work that you've done to integrate the people who have the issues, the people with lived experience with chronic pain, in everything that you've done and what you're going to do going forward. Really, you're launching some long-term solutions here that I'm just saying from my perspective, I think that this is truly something that the Chronic Pain Network can embrace and to help move forward as is possible. So Rachel Bosma put a thank you and an amazing job message in the chat. And what I would like to say on behalf of the TCB team and Rachel is that we're so grateful to the mentors, the facilitators, the members of the KIMS and our TCB committees who supported the beginnings and all of this the work as we could to support you, the hack teams, for over the last year. Your guidance, Megan and Rachel Roy, have been so essential in shaping the projects. We thank the CPN team for the work that you have done to arrange the meetings and keep us on point. We thank everyone who participated today. I'm sure that you are blown away by the level of expertise, the work that has gone in, the forethought, and the long-term potentials that have been created through this hackathon are just amazing. We hope that you will take this energy and the idea of the success of collaborating with everyone, researchers, trainees, people with lived experience, clinicians, all moving this work forward. And Norm, I'm wondering if you would like a moment or two before we end our time, not putting you on the spot, but just did. And so please share a couple of thoughts with us.
Hey, Lynn, you spoiled everybody's perfectly good day. You could have gotten out without hearing me talk. Yeah, it just couldn't. Just could have
I
left
don't think we're spoiling. You have
another
led this.
6 minutes and you would have been clear. But no, I put in the chat, this is remarkable piece of work for the planning and dissemination grant. More than happy to write a letter of support for that. A draft is always appreciated. And everything that was said about pushing this out, pushing these materials out, I think is brilliant. Certainly curriculum is one of the CPN targets for pushing knowledge into effect. And it's real. I was thinking, listening to particularly the pediatric discussion, we talk about evidence-based medicine. One of Dave Sackett's, in fact, I think the first question that Dave Sackett said to ask when you review a clinical trial or an article is, are the patients in this study representative of the patients that I am seeing? And you've heard with a great deal of accuracy the fact that many times they are not. I mean, it's 20 years ago, you couldn't even count on there having been a woman in a study, which meant that extending information about cardiovascular treatments to half of the population was not necessarily your best strategy. We've further defined different populations and subpopulations with either different levels of risk or even different ways of responding to medications. One of our leading urologists in Hamilton died in the course of what should have been a very successful cancer treatment because somebody forgot to screen him for his aberrant response to one of the common anti-cancer agents, and he was dead within 24 hours of receiving it. And yet that piece of information is known and should have been part of the screening. So, and as Nader and others are working on the concepts of biomarkers and genetic predictors. There's quite a bit of work on genetic predictors of people's responses to common antidepressants, for example, a significant number of people. And at Sick Kids years ago, they established that substantial portions of the population don't convert codeine to an active drug. And that's the same thing with buprenorphine. These are known and measurable. And also that some people convert codeine very rapidly to very highly potent morphine. And as a result, there have been deaths resulting from that because of misunderstanding of doses. So focusing on the populations, bringing it down to the patient in front of you, I think is brilliant. And I think both of these things have a lot of space to go. So the 3 minutes I took, Lynn, you can still
Thank
save
you.
people's afternoons.
Thank you. We appreciate your comments, Norm.